course, a lot of advances we've seen lately has been about the perioperative treatment. We know that we can cure early-stage lung cancers quite well with surgery, radiation, but the intermediate stage has not been satisfying for many, many years. But lately, we've seen a lot of advances, both in terms of adjuvant targeted therapy for EGFR ALK-mutated patients, with neoadjuvant chemoimmunotherapy for patients with EGFR ALK-negative tumors. Now, that information is impacting, having it to work through the tumor board. Again, we spoke about the mediastinal workup. That's even more important, than in the past. Biomarker testing. But tell us, Momen, how does the patient's kind of lung function, other elements of their illness come into play when we think about, those modalities?
Yeah, I mean, obviously, patients with lung cancer have the risk factors for heart disease, lung disease, and so, our job is to optimize them, optimize their respiratory function, and so, we often see patients right after diagnosis or ahead of upcoming treatment, whether it's surgery or immunotherapy, and we know immunotherapy can potentially cause pneumonitis. And so for those patients, our job is to optimize them. We make sure that if they have COPD, that they're on optimal medical regimen. We encourage smoking cessation prior to surgery because that really contributes to better outcomes. We have pulmonary rehab that we can enroll patients in. But it gets challenging because patient has a lot of other obligations when they have cancer treatment. Yeah, but our job is to get them to withstand the treatment that's best for their outcome.
Yeah, and after staging is done and decision is made to maybe go ahead with neoadjuvant therapy, the data now is very robust that that neoadjuvant treatment, 3 to 4 cycles of chemotherapy and immunotherapy can achieve great improvement in outcome to the point that in certain biomarker positive patients, just 9 weeks of therapy, 50% of the tumors go away by the time the surgeon removes, where the tumor used to be. Just so exciting for me as a medical oncologist to look over to the surgeon to say, this time I got it out. They might enjoy my comments too, but really exciting, advances. But not everybody's a candidate. Immunotherapy certainly has some potential for immune adverse events, and patients with autoimmune disease, patients after transplantation might not be the perfect candidates. But there's also some challenges after neoadjuvant treatment as to nodal flares, maybe some surgical complexity. Jay, can you tell us how this shifted your practice in the past? Every one of these patients you might have taken to the OR right away. Now you have to wait 3 months anxiously to see in what shape the medical oncologist delivers the patient back to you. How does that process working out?
Yeah, so I think in the U.S. we're accustomed to saying that if someone's medically operable and has resectable disease with stage 3 disease, that they should get neoadjuvant therapy, regardless whether it's single station N2 or multi-station N2. I think the stage 2 is where there's more controversy in the U.S. My personal belief is even with stage 2 patients, your recurrence rates are 60%. So to me, that's still a systemic problem. So I prefer neoadjuvant therapy in stage 2, but I know surgical colleagues would say, that stage 2 is more controversial, and some may prefer to take that patient up front. I think in terms of the surgical complexity, we haven't prospectively collected that data. We've put out grading systems. I wrote a review paper about this in JTO about grading systems for nodal lymphadenopathy and then perihilar fibrosis, but it has not been prospectively collected in the phase 3 trials. So it's hard to get a grasp of, is that just kind of locally advanced disease and expectant, or is that attributed to the chemo IO? It's not entirely clear. And now that we're going to neoadjuvant targeted therapy trials, that level of fibrosis we're seeing in neoadjuvant targeted therapy trials. And again, is that due to the target therapy, or is that just inherent to the disease? It's not so easy to decipher.
A lot to learn, but some of these studies also suggest that maybe you can do lesser surgeries for some of the patients as a result of the neoadjuvant treatment. such as pneumonectomies, maybe the rate we can reduce? Do you see that in practice?
So that data first came out with Checkmate 816 with neoadjuvant chemo and nivolumab for up to 3 cycles, and when you looked at the types of operations that were done, there were less pneumonectomies in the chemo-nivo arm. But when you look at the perioperative trials with IO on both ends, you don't see that difference. So I'm not sure that's a real difference.
Got it.
Yeah.
So there's a lot of talk about these sort of aspirational neoadjuvant candidates. So where do we draw the line? Are we able to push the boundaries to offer neoadjuvant and surgery versus, or some patients still better off with more definitive chemoradiation immunotherapy program like Pacific? Where do you see that boundary lying today?
Yeah, so I think it's important that the surgeon is decisive up front about medical operability and resectability, because you want that patient to give the best chance of completing either pathway, going to a neoadjuvant chemo IO, then surgery, or if you're a perioperative institution, then finish off the adjuvant IO, or go the non-operative route with definitive chemo XRT, then consolidation durva. Either pathway that you think the patient will most likely complete. So then these borderline medically operable patients, I don't think those patients, these are the aspirational stage 3 patients we're talking about. Because when you look at Checkmate 816 and you look at the patients that didn't make it to surgery and what happens to them, very few actually got the Pacific trial regimen. Meaning, is it really feasible to think that we're going to go from chemo IO, neoadjuvant, 3 to 4 cycles, and then switch gears to Pacific? That may not be a feasible or a practical route and a pathway for the patient.
And there's a learning curve ahead of us to figure out what's the right path for each and every patient, but definitely a huge amount of progress has been made. Where do you guys see this in your practices? Is there a lot of this kind of aspirational, let's just give a few rounds of chemo IO and let's just see what happens?
We're following, we have a couple clinical trials in the early stage, and we're following the NCCN guidelines, and we are seeing such great benefit from doing the IO. So it's been an interesting time.
It's hard not to catch the excitement and just give things a try. But yeah, we'll learn a little bit more as to how to use these new tools. But again, that neoadjuvant space to make sure that the patient is actually healthy by the time the surgery needs to be performed. Where's the nursing perspective? Where's the nursing need in that phase?
We do a lot of teaching around IO. So if it's neoadjuvant, and we talk about difference between the chemotherapy versus the immunotherapy, we have a lot of written information about that. And the side effect profile is very different. So it's important for the patients to understand the side effects. We talk to them about what to expect. What are the possible side effects and what are the more concerning symptoms that they may have that they need to call us right away. We practice that I would rather a patient call me too many times than not enough in those situations. So we kind of have a form that we give them. It's kind of like, these symptoms may happen and this is what you do. These are more concerning and these are ones that you need to call us right away. But we would rather have them call us, then we go over everything, because a lot of things can be treated and it's better to treat it early on versus it getting
This is such an important message, and just creating that line of communication, but not just the line, but also that the patient understands that you actually want them to communicate.
Yes. And again, our lung cancer navigator gets a lot of these calls, and then she knows what is okay, and she knows what to elevate and get in touch with us or get in touch with the physician about.